Hello, good evening, everyone. Welcome on behalf of the Myasthenia Gravis Foundation of America to this webinar on MG and U. I'm Jessica Houston Andrade, National Director of Programs here at MGFA, and I thank you all for attending. We'd like to thank Alexion for their generous sponsorship of these webinars that help to enhance our educational offerings to the MG community. Before we get started, just a few housekeeping items. So one item is listening. So each of us can only listen with one device. You can listen with your phone or with your computer. If you do not mute one of the lines, we will have some feedback that could potentially ruin the program. Please make sure to choose which device to use now if you haven't already. To shut off the computer sound system, search for the volume and lower it to the baseline. To mute your telephone line, use the mute button or dial *6. For questions, we will take questions at the end of the presentation to give the presenter ample time to speak on this topic. You may type your questions in the chat box and they will be answered at the end of the presentation during the Q&A session. We'd like to take some time to welcome our speaker. Dr. Raghav Govindarajan is the Associate Medical Director of the Neurology Outpatient Clinic, NDA ALS Clinical Director, and EMG Neurophysiology Lab Director at the University of Missouri. He is board certified in neurology and neuromuscular medicine. He runs a large MG clinic through a multidisciplinary team in addition to a support group for MG patients through MGFA. He has many peer-reviewed publications and more than 30 teaching awards. He has been inducted into the Alpha Omega Alpha Gold Humanism Honor Society, Sigma Psi, and he is elected Fellow of the College of Physicians of Philadelphia and was honored with the Leonard Cow Humanism Award by the Arnold P. Gold Foundation, in addition to the Swartz Compassionate Caregiver Award for the care of his patients. We thank him so much for joining us this evening, and I'll turn it over to Dr. Govindarajan.
Thank you for that introduction, and I want to thank you all for joining me today. Before I proceed ahead, I just want to make sure the audio is clear so you can all listen to me clearly. I just want to make sure we are okay with the audio. Is the audio okay? Thank you.
Yes,
I appreciate that.
Hear you.
Thank you. So the topic I have today is MG and U, and it's a topic that's personally close to me. I spend a considerable amount of time talking to my patients about MG, but also talking about how MG can impact other aspects of their life. The goal of the topic is not to go into details about MG and MG care, but the goal of this topic is to kind of give a 360-degree overview about MG and how MG can affect different aspects of your life and how that can be managed. Let's see. Okay. So the way I have structured the talk is we will briefly talk about understanding MG, treatment of MG, drugs to be used with caution in MG, vaccination, nutrition, and exercises in MG, sleep issues in MG, anesthesia and anesthesia-related complications in MG, pregnancy and delivery and hormones in MG, and briefly talk about driving in MG as well as working, employment, and education with MG. Each of this topic that I'm going to speak today can be an hour or more of webinar by itself. And again, the goal of the talk is not to go into details of all of this, but the goal is to give you a high-level overview about these things. And as the months go by, I hope to focus on many of these topics more individually and speak in more detail about them. I know some topics have already been covered in the past, but those which have not been covered, I would like to focus and talk in more detail. But today I'm kind of giving a high level overview of all of them. The slides have content in them. I never make the slide content too heavy. It's just too difficult to follow. So while there are some content in the slides, most of it would be discussion by me as we go along. So I for one would like to make notes when I hear something. So if you're one of those person who likes to make notes, I would highly encourage that as we go along with each slide. The slide has some details, but more of it will be through discussion as I'm speaking rather than putting all of them in the slide. So those are the two caveats I wanted to highlight before we start the talk. So coming to understanding MG, I always, this is a part I struggle with some of my patients. When your bone is broken, it's easy to say what it means. You can show the X-ray. X-ray shows your bone is broken. You can show it to anyone basically, and they understand what it means. Now try explaining MG or myasthenia gravis to a new patient, and we all struggle. So I always go back to this picture and talk to them about the neuromuscular junction. Briefly, this is what I say. I say that the neuromuscular junction is like your car ignition and the key. So if you, for example, if you have the car ignition and you have the key, the key and the ignition, unless they come in contact with each other, your car won't start. There is always that gap between the car ignition and the key. So the key has to come into the ignition, and that's when your car starts. So your neuromuscular junction is just like that. The nerve and the muscle never actually touch each other. In this case, the nerve is like the key, and the muscle is like the ignition switch. Unless the nerve comes in close contact with the muscle, the electricity cannot pass through them. However, to overcome that gap or the junction, what the nerve does is it releases chemicals, what we call, let's see here. Okay, I think this is the one. It releases chemicals called acetylcholine, and this acetylcholine in turn comes and drops onto these muscle membrane, what you see right here. I'm trying to see, yeah, I think the pointer might work, yeah. So the chemical right here in the nerve has to drop down and come and fall on the muscle. So that's how this key comes in contact with this ignition switch, so that the muscle, which is basically like a car, can contract. So the chemical gets released from the nerve. It comes and falls onto this receptor, what we call the acetylcholine receptor. There are other fancy things that are there in the picture here, and I don't want you to worry about that. All I want you to focus is the key has to come in contact with the ignition switch, and basically here the nerve contains chemicals which are acetylcholine, which come and drop onto this muscle membrane, and they bind to these receptors right here. And once they are bound, the combination of these chemicals, the acetylcholine and the receptor, in turn triggers electrical activity in the muscle and causes the muscle to contract. That's how your nerve communicates with the muscle. This gap that we see between the nerve and the muscle is the neuromuscular junction. So the nerve never truly touches the muscle. There is always a gap, and the way it communicates with that gap is through these chemicals called acetylcholine. I also tell my patients, if you want to capture raindrops in a cup, the only way you can capture them is if you open the cup and keep them outside. So all the raindrops will come and fall into the cup or the pot, and then you can collect them. So basically, the cups that I told you are nothing but these receptors that are there on top of this muscle membrane. And these are the raindrops that are falling down. Now in MG, your body produces what we call bad antibodies. MG, as many of you already know, is an autoimmune disease. So in this autoimmune disease, your body produces bad antibodies that block these receptors. So going back to our analogy, if you want to capture water in a cup, you have to make sure the cup is open. That's how you can capture the water. If the cup gets closed, when the rain falls and the cup is closed, it does not fall into the cup anymore. It falls onto the side or on top of it, and it's no longer being collected. And that's exactly what happens in MG. You have these chemicals falling from the nerve. They have no place to go because these receptors are all blocked by these bad antibodies, and the chemicals cannot go and bind to these receptors. So they come and fall off somewhere here, and they no longer are able to produce the electrical current that is needed for the muscle to contract, and so you become weak. And that's exactly how MG causes weakness. Um, if you want to capture raindrops in a cup, you have to keep the cup open. If you close the cup, you can't capture the raindrops. So if you have to produce electricity within the muscle, the chemical from the nerve has to come and fall on the receptors. But if the receptors are blocked by the antibody, the chemical does not fall on them, and you can no longer produce the electric current. And this is the explanation for how myasthenia gravis causes the weakness that we all know about. And again, it's of course way more complicated than what I have told you, but this gives you like an overview of how the neuromuscular junction works and how the myasthenia gravis weakness is manifested. So going to a brief overview about MG. MG is an autoimmune condition, as we discussed, and typically in MG, you have bad antibodies. You need the antibodies to fight off infection. But in MG, unfortunately, the antibodies, instead of fighting the infection, turns on the body, and ends up attacking the communication between the nerve and the muscle, which is what we briefly went over. When we say MG, everybody thinks that MG is autoimmune, but there are many forms of MG. I shouldn't say MG, many forms of myasthenia, which are genetic. If you go back to the previous slide here, all these chemicals, these receptors, and you see some stuff here called ColQ10, which basically holds the receptors in place. All these are produced by different genes. If you have mutation in any of them, you can develop symptoms of myasthenia, and we call them congenital myasthenic syndrome. And many of these are seen in children when they are born or even a bit later in their life. And they are very different from the autoimmune myasthenia that we are all very familiar with. As many of us know, MG typically starts in the eyes and can stay there for a while, or can go down into your body, affecting your arms and legs. Again, different people manifest in different ways. We will have a brief discussion on that as well. Most patients with myasthenia gravis have antibody to the acetylcholine. Some patients also have antibody to what we call MuSK, and this MuSK is needed. If you again go back to the picture here, you need the MuSK so that these receptors are all held close to each other this way. If one of them is here, one of them is here, and one of them is here, the other one is here, again the chemical that falls, they are not able to bind. If the receptors are all very close to each other, what we call clustered, there is a greater chance that the chemical that's being released can bind to these receptors. It's the same way if you have cups, and if the cups are at different spots, and they are not close to each other, then some may capture, some may not capture. If on the other hand all the cups are close to each other, the chance of capturing raindrops increases. One thing you have to note, there is nothing in your body that's telling that these chemicals should go and bind to these receptors. It happens by chance. So if you have more of these receptors together, the more likely these chemicals can bind. And to have these receptors close together, you need what we call musk. And if you develop antibody to musk, these receptors are again not close by, and the chance of the chemical binding to the receptor comes down, and you get weakness. So you can have antibody to the actual receptor, or you can have antibody to the protein that's needed to keep the receptors together. Newer and newer antibodies are being identified in many cases, and we are just at the tip of the iceberg. And as we go along, we will identify more and more new antibodies. If of course no antibody is identified with all the blood tests, then we call it seronegative. Although among MG experts there is a consensus that many seronegative patients have the antibody, it's just that we have not been able to find them due to various reasons. But if you don't have any of the antibodies that are traditionally tested, we end up calling it seronegative. Different literature says different percentage of patients are seronegative. In my practice, being a large center, it's about 15-20% of my patients are seronegative. I've heard in other centers where about 40% of their patients are seronegative. And in some smaller centers, it may be as less as 5%. So there are many patients who have features of myasthenia. It's just that we have not been able to find the antibody that we need. Now, people ask me, how is MG diagnosed? And my answer to them is very short and straightforward. MG is typically diagnosed by an MG expert. I can give you more long and fancy answer saying you need to do blood tests, you need to do electrical testing, you need to do single fiber EMG, and those are all right and true, but you need an MG expert to diagnose MG. And the link that I have provided here gives the names and addresses of some common MG experts across the country. The link, of course, is through MGFA website. And I want to say a caveat there, it's by no means the only list of MG experts. There are a lot more MG experts out there. It needs an MG expert to diagnose MG. And all the testing that we do, they have relevance, but you really need an MG expert to put all the testing together and look at the big picture. So answer is, if you want to know who diagnoses MG, it's an MG expert who does that. The MG expert might be a neurologist, it might be a neuromuscular physician, it may be an ophthalmologist, it may be even a medicine doctor. Typically, it is a neuromuscular physician like me who is an MG expert, but there could be other people as well who are well versed with MG, and they are the ones who are able to put together all the testing that we order, electrical testing, single fiber EMGs, blood testing, and figure out if it is MG or not. Because a lot of things can look like MG and doesn't mean it's MG. And a lot of things which don't look like MG turns out to be MG. So again, you need an expert. So what do we mean by MG? MG is, of course, myasthenia gravis. Myasthenia is muscle weakness. Myo is muscle. Asthenia is weakness, so muscle weakness. Gravis is, of course, grave. We say gravis and grave. In the good old days, it was really grave when we didn't know what MG was. We didn't have treatments. We didn't have good pulmonary care. MG is rarely grave anymore. In my practice, which is a fairly large practice of MG patients, I have close to 160 patients in my clinic with MG. I can tell you in the last at least 4 years, we have had only one patient pass away, and with MG-related complications. He had respiratory failure and then developed infections and other complications and passed away. And even the sickest MG patients, with all the care that we provide, are able to pull through. So it's rarely grave, um, but that traditionally it was a grave disease. That's why the Myasthenia Gravis. It affects what we call voluntary muscles. Voluntary muscles are typically those which control your body movements, and MG affects these voluntary muscles typically in the arms and leg. It can also affect the voluntary muscles of chewing, swallowing, tongue movement, breathing, and of course eye movement and eyelid as well. It typically does not affect the autonomic system. Autonomic system is one that controls your heart rate and blood pressure and so on. MG typically does not affect your sensation as well. Many of our MG patients have pain. Pain is a common complaint among our MG patients, but MG does not affect the nerves which control sensation. Patients with MG have the characteristic what we call fatigable weakness, where as the day goes on, the weakness gets worse. Most MG patients are stronger in the morning and get worse as the day goes on. Similarly, the fatigable weakness, the harder patients with MG try, the weaker they get. It's not like you exercise and suddenly you get stronger. It doesn't work that way. The more you do and trying to improve, many times the weaker you get. So, and we'll talk about these things in future slides as well. But that's the typical overview of MG. It affects the voluntary muscles, typically starts out in the eye, causes droopy eye and double vision, then spreads down, affects the arms and leg, causes weakness there, causes fatigue there, can also affect chewing, swallowing, breathing, tongue movements, and can have sometimes serious consequences. It does not affect the autonomic system. It does not affect the sensation. So this is a brief overview of how the symptoms of MG can be. In most patients, it starts out in the eye where you notice a droopy eye, and the droopy eye gets worse as the day goes on. Some people also complain of double vision with seeing two things side by side. Some patients also notice that their wrinkles on the forehead have gone, and again, that's a feature. Some of the patients also notice that their mouth is weak and they're not able to close completely. Some patients note that they have a nasal voice and the voice has become soft. Other patients notice that they have difficulty holding their head up and their head drops down. Similarly, other patients notice that their arms and legs are weak. Not all MG patients have all of these symptoms. I have many MG patients who have minimal symptoms in their eyes and the face, but have more arm and leg weakness. On the other hand, I have many MG patients who have a lot of eye weakness, maybe not so much in the arms and leg. I have some patients who have more weakness of the eyes and mouth and less of the arms and legs. So we see a combination of all these. One thing I want to let you know is many MG symptoms can be confused for stroke. So if you go to the ER or the emergency room and say you have difficulty chewing, swallowing, say your mouth is weak, the first thing the ER doctor or anyone there for that matter is going to think is that you are having a stroke. In fact, I have had patients before they saw me, they were diagnosed with stroke and many strokes and put on blood thinners and all sorts of treatment before they came to see me. And then I diagnosed them with MG and took them off of all the blood thinners and every other treatment. And it's unfortunately those things we see from time to time, especially when you are not diagnosed and you have these recurrent symptoms. And if you know anyone, and if you have friends, families who have similar symptoms as what we are discussing today, keep MG in mind and let them know. Otherwise, as I discussed, there is a chance that if you go to the ER or even primary care office or other doctor's office, that many MG symptoms can be mistaken for stroke and not diagnosed at all. Now, a brief overview about MG treatment. Um, every case of MG is different, so every treatment is different. The recommendations that are here may or may not be applicable for you. And I always tell my patients, every patient of my MG is different. Just because one medication worked for a patient A does not mean it's going to work for patient B. Each medication treatment and the regimen has to be customized to each patient. And that's where you need an MG expert who can figure out what medication works best for you. But the treatments I have listed here are generally what are commonly used. We commonly use pyridostigmine, or known as mestinon. Um, it improves the transmission between nerve and muscle temporarily. As many of you who have MG and who have taken mestinon, you realize that it helps you for a while, then the symptoms come back. So it's a short-term measure. It does not do anything to the disease course as such. What I tell my patients is like putting a band-aid. It gives you a temporary relief. And I have many patients who all they need is mestinon. They have some droopy eyes, some double vision. They take mestinon, it gets better, and they're happy with it, and they don't want any further treatment. And that's perfectly fine. More commonly, however, we end up using steroids. Prednisone remains the treatment of choice. We can do prednisone in different ways. You can do them daily, you can do them every other day, you can do them on the weekend. You can start at a low dose and slowly work your way up. You can start at a high dose and slowly work your way down. Lots of ways to use prednisone to treat MG. Again, depends upon your doctor and how they have been prescribing prednisone in the past, and so on. The main purpose of prednisone, of course, is to damp down your immune system and reduce the production of antibodies. And it does that very well. Unfortunately, it also damps down the other aspects of immune system and puts you at risk of infections and whatnot. Um, I had a patient with MG. I started them on prednisone before the new shingles vaccine came out. This was then. Within a couple of months of starting, they got a shingles flare up around their face and the eye. They were about to lose their eyesight from shingles. It's prednisone it's a necessary evil. It helps with MG, but comes with a lot of baggage. But we still use it. It works. It works really well. In many cases, we also use other immunosuppressive therapy, what we call steroid sparing agent. Because prednisone has a lot of side effects and complications, we don't want to use them for a long time. So in order to try to take over the function of prednisone, we use medications like Imuran, methotrexate, mycophenolate, cyclosporin, and rituximab, and so on. Again, different patients are on different combinations of these treatments. Some are a combination of a couple of them to control their MG symptoms. Again, it all depends upon you, your MG, how bad it is, and your discussion with your doctor. We also use plasma exchange and something called IVIG. Typically, plasma exchange and IVIG are used only when there is a flare-up of MG symptoms. But in many cases, if your MG symptoms are not well controlled, plasma exchange and IVIG can be used as maintenance. And there is also a newer medication called eculizumab that you would have heard. It's commonly called Solaris, which is a new medication that we have for MG. Thymectomy is also now commonly recommended, especially after the recent trial, which showed that it makes a big difference in MG patients. Commonly in those patients who have generalized MG and are about less than 65 years age, it definitely makes a big difference. So I recommend thymectomy on all my patients with generalized MG. The other thing I want to talk to you about, once we know about the overview of MG, many medications can make MG worse. And we used to call them drugs to avoid, and I think that's a wrong term to use. We probably need to use, which has been updated in the MGFA, drugs to be used cautiously. There are about 30 to 40 drugs that can make the MG symptoms worse. Many of us take these medications. They are very commonly used, and many of them are very important medications. Example is your medication to control your blood pressure, like metoprolol or propranolol, are also useful for heart, but they can make MG symptoms worse. In many of us, in people who don't have MG, they have no issues, but in MG, your reserve is low, and as soon as you take this medication, there is a chance that it can get worse. But I tell my patients, if you need them, you need them. I don't want to tell my patients, oh yeah, you have MG, you can't take this medication. No way I can give that to you. If you need that medication and that's going to help you, or it's needed for you to do well, or it's needed to take care of that infection, I work very closely with the doctor who's prescribing that. I work closely with my patients, keep an eye on the MG, and we do prescribe those medications. God forbid, if there's a flare up, we treat the flare up. So while the medication says used cautiously, it does not mean we can't use them at all. And the link here has a list to some of the commonly used medications that can make MG symptoms worse. Again, the list is not by no means very comprehensive, but it's a good starting point. And many of you, I'm sure, have carried this list around in your pocket. Given a copy to your primary care doctor, and so on. Again, it's good to keep that list and to try to avoid those medications if possible. But if you need them, you need them. So, vaccination is another thing that many patients of MG commonly ask with me and discuss with me. The benefits of vaccination far outweigh any risks of MG flare up. So we recommend vaccination to all patients. The caveat, of course, is that you can't get live vaccines if you are on prednisone and other immunosuppressive therapy. Example of live vaccine is the old shingles vaccine, which if you get live vaccines when you are on this prednisone or immunosuppressive therapy, in fact, instead of helping you, it's going to hurt you because it's going to cause the disease. So live vaccines are contraindicated, but everything else, other vaccines can be taken. Inactive vaccines, what we call killed vaccines, example, influenza and the newer shingles vaccine called Shingrix, is definitely beneficial for patients. Even the other kinds of vaccines called the capsular vaccines, example, Pneumovax for pneumonia, are also safe in patients with MG, even if you are on prednisone and immunosuppressive therapy. The only caveat here is that if you're already on prednisone and immunosuppressive therapy and you take pneumonia vaccine, for example, your body may not mount a sufficient immune response, in the sense that the vaccine may not help you as much, because you need the immune system to fight the capsule or fight the vaccine so that your body develops resistance. But your body may not be able to do that, and you may not develop adequate response to the vaccine because you are on prednisone or immunosuppressive therapy. And generally, in my practice, I recommend that patients get the pneumonia vaccine and even Shingrix prior to starting all the treatment. And once they got these treatment, then I once they get the vaccine, that's when I start the treatment. Of course, in some cases, you want to start the treatment early, so you end up starting. But in many cases, if possible, I try to get the vaccines in my office or close by to my office. And once they get the vaccine, we start the treatment. Influenza vaccine is yearly, and I definitely recommend that to get influenza vaccine. The risk of MG complications from influenza vaccine is low, whereas if you do get influenza, the risk of complications from influenza on MG and your body as a whole is pretty significantly high. So definitely recommend getting vaccines yearly for influenza. Pneumonia vaccine is once every 5 years. So definitely recommend those two. The other topic my patients commonly talk to me about is what to eat. More than what to eat, the common question I get is there a diet that's going to help with MG? Um, Many of my patients bring books or booklets or handouts or uh, basically printouts from the website about autoimmune diet, where they have read, where they say that if you have autoimmune disease and you follow this diet, your autoimmune disease gets controlled. And my answer to all these autoimmune diets, MG diets, is that we don't know enough about them to say if it's going to work or not. And I tell my patients, don't end up spending a fortune on buying these autoimmune diets and other stuff that are advertised, because none of these are covered by insurance, and we don't know if they're going to work. And in some cases, I always make sure I closely read what the diet contains, and if there are things that I'm concerned that can make their MG worse, I kind of say no to it as well. Besides that, this is the general recommendation we give for MG patients. Myasthenia may cause symptoms of muscle weakness and fatigue, as we all know. So it is important that you eat in between a little to keep energy levels up. It's not that you have to eat a lot, but you need to snack periodically so you keep your energy levels up and reduce the fatigue. Of course, if you're able to prepare food in advance or prepare food which are quick and easy and you don't have to spend so much time standing and cooking in the kitchen, that definitely helps. But in some cases, it may not work out. But that's I generally recommend that you have food prepared in advance and do things which are easy and snack periodically so you keep your energy levels up. Um, some of you also have difficulty chewing and swallowing, and may need softer foods, and that may be something you'll have to discuss with your doctor and figure out what food might be best for you in terms of of eating soft food. Um, if you lose weight with MG, which can happen, typically you gain weight because of prednisone. But if you have difficulty chewing, swallowing, and you're not well, and you lose weight, which can happen in MG patients, you will need to see a speech and a language therapist and a nutrition specialist or a dietitian and work closely with your MG doctor to figure out a diet that will help you to gain your weight back. Um, and always make sure you consider bone health in all the diet that you eat. All the medications we give, including prednisone, can worsen bone density, cause osteopenia, osteoporosis, and increase risk of fracture. So always keep that in mind. My patients ask me about alcohol intake, and I say moderate alcohol consumption once in a while is okay. I mean, we don't have any data on these, but moderate consumption is okay. So that's the advice I give. So make sure you snack periodically. Make sure you eat healthy. Make sure you keep bone health in mind when you prepare your meals. If possible, prepare food in advance or prepare food which are easy to do, so you don't spend too much time and energy cooking meals. If you have difficulty chewing, swallowing, use softer food, what we call mechanical soft diet. If you are losing weight, you need to consult a dietitian and a speech language pathologist to come up with a treatment plan to help you with gaining your weight back. The next one I commonly get asked by my patients is, can I exercise with MG? And the answer is yes, you can. We always say eat well, rest well. But here is the caveat: you have to learn to listen to your body. With MG, you will have good days and bad days. So, and it's not like you exercise a lot and you get better. No, if you stress yourself more, your MG symptoms will flare up. You may or may not know when you are exercising, but you will pay price for it for the next few days. So know your limit, learn to identify when the fatigue sets in, so you stop exercising right before that and don't push through it. Take frequent naps in between and spread out your activity. And this is really hard for us. It's easier said than done. I say this, but I myself find hard to follow this sometime. But in MG, it's critical that you pace yourself and spread out your activities. If you don't do it and you push through it, you will pay a price for it for the next few days. And for those of you who have MG and who have gone through this, you can all agree with me that you need to pace yourself and learn to listen to your body. Again, temperature changes can have a lot of effect on muscle function and weakness. High temperature, low temperature can all do that. So you need to keep that in mind as you push through. I live in mid Missouri. Uh, Most of my patients are farmers, and they are used to working outside. And I have a few patients who are farmers who have MG. It's really hard for me to tell them to pace yourself. They're used to getting up at 3 o'clock in the morning, taking care of their farm, working until 6, 7 in the evening. And with MG, I mean, it is really, really hard for them. And I tell them you need to you need to pace yourself and spread out activities. Don't overdo it. It's really hard. One day I got a call from a patient of mine. She is a 22-year-old girl with MG, and she says that her MG symptoms have flared up. Medications are no longer working. We need to make changes. And I talked to her, I talked to her mom, and as I talk and as we go along, I realize she's doing CrossFit exercises. These are really intense, high energy exercises. Um, Even those who don't have MG, they get tired very easily with those. And if you have MG and you're doing CrossFit, I mean, it's going to take a toll on your body. And so it's not that the MG was not well controlled. It's just that CrossFit is really hard to do with MG, and so you need to know your limits. And of course, we made a change in that, and her symptoms are better now. So um, Tai Chi is one thing that I strongly recommend my MG patients. Tai Chi helps with a lot of other neurological conditions and also helps MG patients, where you don't have to overexert yourself, but also keep your body and mind physically fit and sharp. The next topic I commonly get asked about MG is about sleep. Sleep apnea, whereby you stop breathing at night, is very common among MG patients. It's often under-recognized and under-treated. I have many patients who are sent to me for second opinion, saying their MG is worse, they have a lot of fatigue, what can we do? Do we need to add more medication? And it turns out that many of them have untreated sleep apnea. And I treat the sleep apnea with a CPAP machine or a BiPAP machine, and they are way better. Their fatigue is much better, their MG symptoms are much better. So sleep apnea is a common thing that you need to keep in mind. Not all typically sleep apnea patients are known to snore, they have headache in the morning. Not all patients present that way. Many patients with sleep apnea, in fact, they present with complaints saying that they're restless all night, they're moving all night, they have excessive sweating at night, they have to wake up frequently to pee and go to the bathroom. These are many features of sleep apnea that that doesn't get recognized, and many doctors just brush them away, or patients in fact also may not tell the doctor. But many of these can be features of sleep apnea which are not treated. Not all sleep apnea patients have the classic history of snoring, stopping breathing, early morning headaches, and so on. Many of these, what I told, frequent urination, excess nighttime sweating, restless at night, they're all features of sleep apnea. Many of my sleep apnea patients who have MG, they also don't dream. If you have sleep apnea, you don't dream. Your dream goes away, and it's a common complaint among our patients. And once we treat the sleep apnea, the dreams come back. So keep these things in mind. And if you have features of these, think about getting a sleep study. The other thing I always recommend, as I previously told in this slide, that sleep and nap helps MG. In fact, studies have been done which show that if you sleep and take power naps, your MG symptoms are way better because of improved neuromuscular transmission. So pace yourself. If possible, take frequent naps to help with your MG symptoms. and they definitely make a difference. So sleep is an important part. Taking frequent naps and power naps in between definitely helps with MG. If your sleep is not well, if you're achy, if you're tired, if you're wake up multiple times at night, you're fatigued all the time, and you feel your MG is uncontrolled, think about sleep apnea. If you have sleep apnea, you will need a sleep test to prove that, and if you have it, using a CPAP or a BiPAP machine makes a big difference in your MG symptoms. And keep these things in mind. Um, Sleep apnea is very common, and patients with MG have more than twofold increased risk of having sleep apnea, and that's an important part I would like to stress there. The next two topics are also commonly asked by my patients. Unfortunately, surgeries, anesthesia, dental care are a part and parcel of our life. Just because you have MG does not mean you cannot have any of these procedures done. If you're undergoing a major surgery and if your MG is not well controlled, we generally like to give you IVIG or plasma exchange a week before the procedure to tune you up and then undergo the procedure. So I've had patients who have undergone neck surgeries, back surgeries. I've given them IVIG, tuned them up, make sure they're okay, and then undergone surgery. So again, you need a multidisciplinary team to take care of you with MG. And you need to have an MG expert who can identify these things and work closely with the anesthesia and the surgeons and so on. Um, if you have MG and you're on prednisone, I, I I tell my patients if the surgeons are okay to continue with the prednisone. Some cases the surgeons want to come off of prednisone and other immunosuppressive therapy because it delays wound healing. And if that's the case, I discuss with the surgeon and taper them off. But I do put them on other kinds of treatment like IVIG or plasma exchange. In many cases, the surgeons are okay if the patients are on steroids, and we continue with them. And if you have been on steroids long term, you will need stress dose steroids prior to any procedure. And your anesthesia team and surgery team are really well aware of about these kind of things, and they will generally figure out these things. I also continue mestinon or pyridostigmine even preoperatively and even postoperatively. I never stop them cold turkey because it can precipitate MG crisis and MG flare-ups. So we always continue treatment. There are different kinds of anesthesia people use. You don't have to know all of them. What you need to know is certain kinds of anesthesia. For example, what we call dexamethasone, they don't work as well for MG patients, whereas other kinds of anesthesia like atracurium, rocurium, they work well, and they're used for many surgical procedures. When you have MG and when you're on these medication, all anesthesiologists and surgeons, they monitor your muscle paralysis and weak and how your muscles are working by what we call a peripheral nerve stimulator. So they know how the muscles are working, so they don't give too much of it. Again, you don't have to know all the details, just have to know that the modern day anesthesia care is really, really good. Most anesthesiologists are very well versed with MG and how anesthesia needs to be done during MG, and most times things work out well. Um, if you have a team of doctors and anesthesists who are not familiar or comfortable with MG, you need to get your MG expert involved in your procedure. In most cases, they are comfortable, but if they are not, then you need to get them involved. Similarly, dental care is another thing that we talk about with MG. Many MG patients have mouth weakness and also have difficulty holding up their head or even swallowing. And these are some things you need to discuss with your dentist prior to any procedure. In fact, whenever my patients are undergoing dental procedure, I talk with the dentist, explain to them about these things, and we figure out a plan. For example, there is something called a mouth prop to help you keep your mouth open so it doesn't completely drop down. Patients also have suction that is controlled by them so that they don't drool or choke. And In other cases, if there is a concern for choking or regurgitation, there's something called a rubber dam which can be kept inside the mouth so it doesn't happen. Again, these things your dentists are familiar with, many MG experts are familiar with, and if you work with them, these things generally go smoothly. But I just want you to be aware of these kind of things that they can happen. Um, Pregnancy and MG is a really complicated topic. I just want to highlight few points here. Um, I talk about pregnancy with all my MG patients who are in that age group, and we always try to come up with a plan. But of course, pregnancy can happen unexpectedly. So if that happens, I tell my patients never to stop medications cold turkey. That's one thing I always tell them. They always call me and we figure out what needs to be done. And you need to have a multidisciplinary team taking care of you during pregnancy, delivery, and even postpartum after birth. I generally have a high risk OB doctor as a part of my team, and we work together on pregnancy and postpartum. If your MG is well controlled, your pregnancy will be normal, your delivery will be normal. But in many cases, it may or may not be. And if that's the case, we have to figure out what would be the best way to deliver the baby. In many cases, it may be a C-section, and that's where the team of doctors comes into play. Many of the medications we give, like prednisone, more than prednisone, other medications like Imuran, Cellcept, they are all toxic to the baby. And again, there is always a risk of complications with them. And again, better to discuss with your doctor prior to planning pregnancy, and rather than having it unexpected. Um, for my patients, if they are not planning family, then I recommend to use two forms of contraception so as to avoid any unexpected pregnancy. So again, that's something you'll have to discuss with your MG doctor. If they don't bring it up, you will have to bring it up and discuss with them. Babies who are born to mothers who have MG can have what we call transient myasthenic weakness. Most of these will go away by 15 to 20 days, but they need to be closely observed during that time. Um, and again, we typically work with the pediatric doctors to figure these out. Driving is another thing my MG patients ask all the time. And as soon as you hear the word MG and you give the diagnosis and how it's going to affect you, most patients fear that they will not be able to drive again. And that's not the case. I have many patients driving long distances. I have truck drivers who have MG who drive long distances. Um, you have to be careful about double vision and driving on busy streets. I had one patient, he had eye MG or ocular MG just in the eye. He thought he's doing well, suddenly developed double vision as a part of his MG, and he's driving on the highway and he can no longer drive. He's seeing two of everything, two of all the cars in the streets, and he had to pull over and was about to lose his license. So you have to be aware about double vision and blurry vision that can happen with MG with driving, and take necessary precautions. Many of my patients take medications just before they are driving, or avoid driving late in the evening or night when the MG symptoms are bad. And in some cases, many of my patients also have glasses that they wear when they're driving. Again, these things, it's not that you can't drive, you just have to be cautious, know your limitations, take medications if needed, and prepare accordingly instead of just trying to go for driving right away. The last part I want to talk about is employment and education. Most MG patients can continue to be gainfully employed. It's not a sentence where if you have MG that you can't work anymore, your life is done. No, that's not the case. MG can be treated, MG symptoms can be controlled and managed, and you can be gainfully employed. Changes may be needed at work depending upon kind of work you do. I also recommend my patients to have a FMLA paperwork handy in case you have flare up. You don't miss work without notice. if you have the FMLA paperwork, it always helps you. So all my MG patients who are actively working, I make sure we fill out a FMLA paperwork and it's part of their file in their office. Of course, I have MG patients whose symptoms are really bad, who are unable to work, and we end up applying for Social Security disability and whatnot. And those can happen. But many patients, they can be gainfully employed. Um, Depends on the kind of work you do, and might be helpful to have FMLA paperwork on file. If you are in school, again, MG should not stop you from completing your school and achieving your dreams. Education of school staff and nurses is critical in MG. In fact, I had one patient and they had no idea about MG. She got bullied in school and the teachers never came to her help. She could not get medications on time. So I just went to the school and gave a talk about MG. And once people heard about MG and they realized how it can affect uh, patients, they had better understanding, and the nurses actually became part of the care of MG patients. So the patient could get medicine on time. In some cases, you may need an IEP to complete your school, and that's okay. And again, that's something you can work with your school as your MG experts and have those paperwork done. MG should not stop you from achieving your dreams, and if IEP is what will help you to achieve your dream, so be it. And I have done many of these IEP paperwork as well. So I definitely encourage patients to continue their education, continue their work, and we can always educate and do the necessary paperwork that's needed for you to continue to progress towards your goal. With these few slides, I want to conclude my talk, and I want to thank you all for being here today, and I'm happy to take any questions that come.
So please, we'll open it up for questions now, so you can enter them into the chat box. The first question we have is from Laura, and she asked, what type of glasses help your patients when driving?
Yes, I mean, especially if you have double vision, there are special prism glasses that can be added to your regular glasses that will help you with it. And typically, I work with ophthalmologists on this, and they are able to figure out what kind of prism glasses are needed and whatnot.
Thank you. Another question we have is from Louis. What new antibody tests are coming? What about stem cell and gene therapy?
New antibody, there is an antibody testing called LRP4. It's not that new, but it's hard to do it. You can still do them. There are very few labs which do them. Newer antibodies for other targets of MG are being identified, and they are yet to commercially come out, and eventually they will come out. With regards to stem cell and gene therapy, I'm not sure on gene therapy. MG, the typical MG that we talk about, is an autoimmune disease, and while there is definitely a genetic predisposition to autoimmune disease, we are a bit further away on figuring out gene therapy. We still don't know if there is a gene that typically causes MG. We know there are certain gene markers that increase the risk of MG, but we don't know if there is one gene that causes MG as such. You see my point? Stem cell therapy, yes. Stem cell therapy is a big thing. It's people, all patients, be it patients with Parkinson's, Alzheimer's, talk about stem cell therapy. The question that we always have, the issue that we have is, with regards to stem cell therapy, commonly done treatments are those where you can convert your skin cells into nerve cells. In this case, you may need to convert skin cells into those receptors that I showed you, and that's a bit further away. It's not easy to convert your skin cells to those, but I'm sure people are working on it, and you will have more information in future. But right now, both gene therapy and stem cell therapy are a bit further away on the MG world. simply because MG is more of an autoimmune disease and we are focused more on treating the autoimmune part rather than the other two components that were discussed.
Thank you. And we have a comment from Craig. He just wants to extend his thanks that you covered the dental issues.
Oh, absolutely. It's more common than we think, unfortunately.
And another question that we have from Cynthia. She's curious why some of us get severe muscle spasms, and how is that possible when the acetylcholine receptor is being blocked?
You're right. So muscle spasms, I suppose you mean cramps. The medications like mestinon itself can cause spasms and cramps. That's a side effect of the medication. On the other hand, because you have MG and because your muscles become tired and fatigued as they are not able to contract well and you are stressing them, they can go into spasms. I have one patient, she's on Flexeril, Baclofen. All these medications can also make your muscles weak. But she has severe cramps and spasms, as you have noted. And it's a part of the MG spectrum itself because you need the nerve impulse to keep your muscle working. If the impulse doesn't reach the muscle, your muscles don't work well. They become tired easily and they go into a spasm. And that's again, unfortunately, a part of MG. And if your MG is really, as your MG gets well controlled, these symptoms become less and less. But it's a part of the MG spectrum.
Another question that we have is from Jim. How successful have you seen getting off of prednisone after the removal of the thymus for non-MuSK types of MG?
Yes, so it's not an immediate thing I have noticed. In patients whom we do thymectomy, over a period of next 3 to 5 years, or at least 3 years post thymectomy, many of the patients have come off of prednisone or on a very low dose of prednisone. So the effect of thymectomy is not immediate. I mean, it does help, but it's not like you do thymectomy today and you are able to come off of prednisone in the next couple of months. It is not. It's over a period of next 3 years, 4 years, where the dose of prednisone is slowly reduced and you need less prednisone as compared to someone who still has a thymus. So I have many patients who have undergone thymectomy and who are on basically mestinon or just Cellcept or mycophenolate. They are not on any prednisone. But again, it was not an immediate thing. It does take a while.
Another question we have comes from Galina. She says that she recently had an enlarged parotid gland and ear problems. The doctor gave her meclizine. She only took a third of the dose and then slept 14 hours. Could that be a medication issue?
Yes, it can be. Meclizine makes you drowsy. It's not MG that's it's not that you have MG and you took meclizine. If I take meclizine, I'm going to sleep for 14 hours. It's a side effect of the medication.
Another question we have is from Salvatore. How long does it take for someone with MG to go into remission?
Variable. People say 5 years, people say 7 years. I've seen all kinds of numbers floated out. I have a patient, she was diagnosed with MG in 1970s. She still has symptoms. So, in her case, she has never gone into remission. But, with all the new treatments that we have with thymectomy, I would say definitely there is a chance. MG symptoms, your symptoms typically flare up the first couple of years of your diagnosis. Are really bad. By 4 to 5 years, they kind of slowly come down and then they kind of become quiet. I don't want to say it ever truly goes into remission. I had a patient once whom we thought was on remission for 15 years, and then the MG came back and she had to undergo tracheostomy because she went into respiratory failure. So the literature has different numbers, but I think in our real experience, the answer is it's going to be there with you for a long time.
Another question that we have is from Gary. How long before Imuron takes effect so he can get off of prednisone?
Typically 6 months, depends on the dose and how much is he on. But people say anywhere close to 6 months or even a bit more longer. I would say 6 months, and then If in some cases it may be less than that, it may be like 3 months. So I would say 3 to 6 months would be the target I would give. And you can't come off of prednisone all the way. You will have to taper it down. People have done studies on all these, and there's no better medication than prednisone. Medications like Imuran, Celsep, they work, but they never work as good as prednisone. So we have to give them some time for them to work, but also taper down prednisone very slowly. So it's not like you are on them and you can stop them right away, because your symptoms will come back.
A question that we have from Josie: can surgery correct double vision?
Yes, it depends. The question would be, if the MG symptoms continue to worsen, whatever surgical correction you have undergone may not work and it may come back. If you have more of what we call fixed weakness, it may. I generally prefer using prisms, because the prisms, at least you can change the power of those prisms if you get worse, rather than going for eye surgery.
A question that we have from Faith: is CBD oil, cannabis oil without THC, safe for MG patients?
There are no clinical trials to say if they are safe or not. In fact, we don't have any clinical trials on CBD oil and many of the conditions for which patients take it. And I'm from Missouri. We recently legalized medical marijuana as well. And I already have calls from my many MG patients saying that they want to go on medical marijuana. So, answer is I don't know. Those patients who have taken CBD oil on their own have noted that their spasms, cramps, pain is much better after taking CBD oil. But again, this is anecdotal evidence. I don't have a concrete evidence to say one way or the other. CBD oil is probably safe, but again, it's the issue with all these is many of these people who make CBD oil, they are not well regulated. It's not FDA regulated, so you don't know how clean they are. See my point? And many of them are compounding places. You don't know how they get the how is the CBD oil made? Is it mixed with something, and you don't know what is there in that. So that's the issue I have with them.
A question that we have from Christine: my neurologist and I have discussed a bone marrow ablation as the next treatment step. What has been your experience with using bone marrow ablation or stem cell transplant to treat refractory ACHR-MG?
I don't have any patients that have used bone marrow transplantation or stem cell transplantation. But I don't have personal experience, but I have other MG experts that I have spoken to, who have discussed this, and there are both pros and cons of it. I mean, undergoing a bone marrow ablation with stem cell transplant is a big procedure, and you will need to be on lifelong treatment and risk of all sorts of infections and complications. And the question is, how severe is your MG, and is it worth doing this kind of ablative transplantation and surgery, bone marrow transplantation and stem cell transplant, to treat your MG? Because I don't know. It depends on how severe is your MG and where are you in the MG to undergo a very, let me say, a very high risk procedure to treat MG. We have newer medications coming out for MG, and one of them I already showed, eculizumab, and I'm not sure if Christine has tried that medication. And if she has not tried, I would highly suggest to go on that medication. If she has tried, it's a different issue, but there are newer medications also coming out. And again, the question would be, is the risk of bone marrow transplantation, is it worth taking that risk to treat your MG? So,
a question that we have from Gary: why is thymectomy not recommended for people over age 65?
It's not shown to have, I don't want to say it's not recommended. I would say that the the benefits are not as much as compared to someone who's a bit younger. So it's always a question of risk benefit. So if you're undergoing any surgical procedure, the risks of surgery and complications, so it's shown to be more beneficial in patients who are a bit more younger as compared to 65 and above. If I have a 70-year-old and he has a thymoma, for example, I will definitely recommend thymectomy. But if it is routine thymectomy for MG, I will say exactly what I said. I don't know if it's going to help you as much as someone who was in their 60s. So it's a decision you and I have to make whether it's worth that risk or not. And if you think that there's a chance that in future the amount of prednisone you are on will be less, or you may not be on it, and you're okay to take that risk, we optimize your MG and we do it. Less than 65, definitely, it is, but after that, it may or may not help as much.
A question from Galina. I read about an apnea device that is just a mouthpiece but not a machine. Is that an option?
Yes, it might be an option. Here is the thing though with that. It's called Inspire device. Many MG patients also have something called central sleep apnea, not just peripheral sleep apnea or obstructive sleep apnea. And if you have central sleep apnea and a greater part of your sleep apnea is central sleep apnea, you won't qualify for that. And that's why having a sleep study and figuring out how much obstructive sleep apnea you have, how much central sleep apnea you have is an important part. Similarly, if your BMI, your body mass index, if it is more than 32, you won't qualify for it. And if you have Medicaid, you won't qualify because Medicaid doesn't want to pay for it. So these are some issues to think about if you are going to take that Inspire device. There are also other mouthpieces people use for milder sleep apnea, and there are other dental devices that many orthodontists are able to create to help you with sleep apnea. And if you have a mild sleep apnea, they work, but if it's anything more than mild, they don't work.
A question from Erica. I have autoimmune MG. Besides vaccines, how can I protect myself when I'm in crowds?
Yes, I mean, it's a great question. Vaccines definitely help, but you can't live in a bubble. I have a patient with MG. I was so happy that I've controlled all her MG symptoms. She's doing really well, and I was patting myself on the back. And I go and I talk to her, and I realize that she basically has shut herself inside her home. She doesn't want to go to her relative's home, doesn't want to go to movies, doesn't want to go to market because she's worried that she's going to catch some sort of bug because she's all on and all of that. And the answer is you can't live in a bubble. There is always a risk of infections. Sometimes the risk of infections that we talk to you about, I think sometimes they are, we may exaggerate them, but there's always a risk. If you eat healthy, sleep well, your immune system automatically reboots and protects you against many of these infections. So healthy living, sleeping well, eating well, definitely makes a difference. So it's not that you have MG and you can sleep when you want, eat whatever you want. It's not that way. Eating well and sleeping well, they definitely help. So if you want to protect yourself against infection, doing those things definitely help. And following general hygiene and precautions are key. I mean, washing your hands and those kind of stuff, they definitely make a difference.
Another question that we have from Ruth, does MG affect bowel function?
I'm sorry, I didn't hear the question.
Does MG affect someone's bowel functions?
Not typically. Not typically. MG typically affects what we call voluntary muscles. So it should not typically affect bowel function. When my patients say they have issues with bowel or bladder, I try to figure out what they mean by that. If you are on mestinon, for example, it can affect bowel function. Mestinon can cause tummy cramps and diarrhea. So I don't know if that's what Ruth is trying to refer to. So they may have to figure out what bowel function means and see if there is something else causing it. So MG typically does not do that.
And then we have a related question from Denise, whether intermittent urinary incontinence can also be related to MG.
Not typically. Again, I have seen MG patients who have urinary incontinence. It's not a classic feature of it. So again, before I say it's MG and jump onto that, I always like to rule out other things that are causing bladder and bowel issues before I say I blame it on him.
And then this looks like our last question. So this question comes from John. What is better for sleep apnea, CPAP or BiPAP?
Answer is, if you have MG and sleep apnea, I would prefer something similar to BiPAP than CPAP itself. And there are several reasons for that. There are also certain BiPAP, something called Trilogy, which might be helpful in MG patients. Typically, when you wear CPAP, it gives you pressure only when you breathe out. So when you have sleep apnea, your airway collapses when you breathe out. So the CPAP machine gives pressures to keep it open. With BiPAP, it gives you pressure both during breathing in and breathing out, and helps with your breathing both during inspiration and expiration. Many MG patients have issues with breathing both during inspiration and expiration, not just during expiration. And again, you need to go to a specialized sleep center who can figure out what you need. But I would say BiPAP and Trilogy would be a better option. Again, depends on what kind of MG you have, how severe is the sleep apnea, and all of those more finer details.
So I think that wraps up our question and answer session for this webinar. I want to thank you so much, Dr. Govindarajan. As you can see from the comments in the chat box, people are extremely thankful. Some people wish they lived in Missouri so they could be treated by you. So this has been very informative, and I want to thank all of our participants for joining us on the line and for your wonderful questions. This webinar will be posted on our website, which is myasthenia.org. We're going to post it by November 30th. So if you didn't have the chance to join, or if there was somebody that you wanted to share it with, you can certainly find it there as well. I'll also share the link. We recently released our Fall Focus magazine at MGFA, which has a lot of articles around exercise, nutrition, and things like that that might be helpful tying into some of this webinar. So I'll share the link over the chat box there. But I really just want to thank everyone. And after this webinar, you'll get a post survey just to kind of gauge what you found helpful to help shape future programming, to make sure that we're developing content that's helpful for you and relevant for the MG community. Thank you all so much, and have a good evening.
And thank you to everyone. Thank you for having me for this talk.
Thank you.